Welcome everybody to this week's Zoominar. We're very fortunate to have Nick Reich joining us this week. Nick is an associate professor in the School of Public Health and UMass Amherst. And he's, for quite some time, he's been working on complex and dynamic disease systems. He's a statistician, develops statistical methods, and does a bunch of other applied work. He also likes to build good visualizations, and that's one of the things we have most liked about his recent work related to forecasting COVID-19. It's mostly deaths, right, Nick?
Yeah, we've started to do some county level case as well, but mostly deaths is what we've been public about.
And his work, I know I've read about it in 538. That's great. Congratulations for that. So today we're going to be asking him about what this is all about. What is it that he's doing exactly? And hopefully we get to learn a little bit about these forecasting models that are kind of, there's a lot of different ones and they're kind of all over the place. But looks like they're giving kind of similar answers, but let's let Nick tell us about all this. Okay, so thanks again, Nick. And I'll go ahead and start. So can you give us, now I've been following someone, so I know a bit, but not everybody necessarily. So maybe you can give us a quick overview of what the COVID-19 Forecast Hub does.
Sure, I'd be happy to start there. So hi everybody, thanks so much for joining. Maybe I'll start just by sharing my screen. I think most people will be able to sort of explore this on their own, but at least sort of point you to the spot to get started. So we have, can you see this here?
Yep. Good.
So this is the website that we launched belatedly. So we're doing this for a couple months, and then at some point we said, we should probably have a website about this. So you can go and browse and sort of read as I'm talking. But basically, with the support, both financial and collaborative support from CDC over the last 3 months, we have been building essentially a forecast aggregation tool to gather forecasts of COVID-19. We've been focusing on deaths, both looking at separate forecasts for cumulative deaths at the national and state level in the US, and then also incident deaths. We've been really focusing on looking at this at the weekly level because daily numbers fluctuate quite a bit for reasons that aren't true signal, but are just sort of figments of reporting. And recently we've also started collecting forecasts on county level case, new incident cases at the county level and state and national level as well, with the hope that those might be used to inform vaccine trial site selection because all these vaccine trials are spinning up over the next few months. So basically this started as a fairly small project. In the first weeks where we did this in April, we had just 6 teams or so, or 6 teams. And then now we have, I think it's over 25 teams submitting models weekly to this system. And as of mid-April, we've been building an ensemble, so essentially a combination model that combines a subset of the models that we get to create sort of a single aggregated prediction. And all of this is visible on the CDC website. So if you go to the CDC, I think if you just Google maybe CDC COVID forecasts, you'd find this page. And every week, the CDC posts a sort of summary, both some sort of interpretation of what the forecasts are saying, a plot that includes the individual forecasts, as well as the ensemble forecasts that we generate each week. So this is now a week old. We're literally, as we speak, this ensemble is being generated for this week. We have sort of a deadline on Monday evening. And so we sort of do a weekly update on Monday and Tuesday. And the CDC site usually gets updated on Wednesday or Thursday.
So I want to interrupt you with a technical question. How
Yeah.
do people submit automatically through GitHub, or do you have some other
Yep.
format, some a web
So,
browser that lets you do it?
so we're sort of, basically it's all done through GitHub. So it's a public site. Any team can submit a forecast um, to this repo. This is by far and away the biggest, the biggest and most well-trafficked and highly contributed to repo anybody in our group has ever run. So you can see we have well over 3,000 commits already, a lot of forks, a lot of people watching it.
So you
And
give people
basically
permission, or they
they
do a what is that,
the pull request.
a pull request?
Yep. So teams, anybody can create a pull request on this repository. Nobody has, just a very limited number of our core team has actual rights to push directly into the repository. But teams create pull requests, and anybody can create a pull request. And we have a lot of validations that go on to ensure that the data is in a very particular formats. And so we've used a lot of continuous integration, both GitHub Actions, but also Travis continuous integration, to sort of ensure that all the data that comes in is in a very strictly formatted. So in this data processed folder, there's like one folder for every team. There's a file for every forecast, and every time teams submit stuff, this
Aren't you running out of space on GitHub,
this gets
or
updated. We're also that's a
aren't you
great
running out?
question. Yes, probably. They haven't complained yet, so at the moment we're just kind of.
I guess they might not. I know they don't. If a file is too big, they'll say something. But maybe if it's a bunch of little, not so big files, it's not an issue. Well, we'll see.
Yeah,
That's
yeah.
not.
So I'll also mention that we're in preparing for a post GitHub, but potentially needing to move post GitHub. We're also maintaining a separate website that this is a website that my group has been developing for a few years. That's basically designed for this purpose. It's still sort of in beta phase. We've sort of accelerated development on it as of January, when we realized that it might actually be put into use. And so this is essentially a formal database backend to everything that's on GitHub. So we're sort of mirroring the GitHub forecast here with a very sort of more extensive structure and queryability. And it's actually turned out to be, I think, less useful for the teams, but more useful for us as a sort of a backend tool.
Interesting. And then how do you share the results with the CDC?
So at the moment, the CDC, mostly they just pull data straight from GitHub, and they have a few analysts there who sort of pull the data and create the figures. And we sort of worked with them a little bit to mock up some R code in the early weeks that they had then adapted and turned into the figures that I showed before. But they basically just pull it down, as does. So I would say the two most sort of public displays of this data are both on the CDC page, which we know is getting on the order of like 10 to 20,000 hits a week. And then also the 538, they have a COVID-19 forecast tracker, and they pull data. They may have it automated, I'm not quite sure, but they sort of pull data as it gets pushed in and then update their forecast tracker.
Interesting. Okay. Cool. And this is all more technical question. Apologies if people find this too technical, but the analysis is done in R, or are you doing something more industrial?
All of the analysis is done in R. I mean, if we get into sort of talking more about it, you'll see there's not much that is about the analysis that we're doing that's super technical. I mean, there's some stuff, but it's not like we haven't needed something that's more sort of industrial strength.
Okay.
The visualization is done in D3 and JavaScript, so that's a little bit more, maybe a little bit more lightweight.
Okay, good. I see. All right, interesting. All right, good. All right. Well, were you done with your explanation, or you still have?
Yeah, no. I mean, I think that's sort of the overview of like what we're doing, who's consuming this, who's using it. We've been really happy to see that the CDC has been sort of been willing to sort of publicly stand behind these numbers. The Robert Redfield, the director of CDC, tweeted out a few weeks or maybe a month or so ago, saying something like, we're tracking 12 models and they're all predicting that we will have 100,000 deaths by June 1st. Yeah. And I felt like that was a really a sort of a clear communication about what we were seeing. It was sort of communicating clearly the consensus among all of the models, which was really important. And this was like the same week that Trump had been saying that we were going to top out at 70,000 deaths. And so I think this sort of helps provide a little bit of a evidence-based narrative especially when there's a lot of consensus behind these models. And when there's not a lot of consensus, then that's reason to look a little deeper and try to figure out what's going on too.
I like that the winner, or at least the aggregator, is a linear interpolation.
it's I mean
extrapolation. Sorry, yeah. Linear extrapolation. Right? Is that what I'm saying?
Well, you're saying. I mean, yeah. Basically. This is for cumulative deaths. So,
I see. Okay.
So it is, but yeah, we found that basically we have created a baseline, what we call a sort of a reference baseline model that does just that. It takes the however many deaths occurred in the last week and just kind of extrapolates that forward. And it's we've been surprised, and I would say a little disappointed that more teams don't beat just that very simple model. There are a few that consistently beat it, but it's in the low single digits.
But what if you go further though? What if you go, because this is just 4 weeks, I imagine once you go further, it stops being linear. It starts, I guess, leveling out maybe.
Yeah. So it's hard. I can show some other figures. So this is our interactive thing, and maybe the best thing to do is to show incident deaths, because I think this is maybe a slightly more intuitive curve. But so here's our baseline that's sort of doing a probabilistic version of just projecting forward. But to answer your question about longer term, so this is something that we've been thinking a lot about, sort of how far we should be projecting in the future. 4 weeks is in some ways a remnant of our work doing flu forecasting with the CDC, which is what's gotten us to this place in collaboration with them, that we have been working with them for 3 or 4 years on doing flu forecasting. I think I guess my feeling on the sort of horizon that we're looking at is that from just the data, I think you can get good signal about what the next few weeks hold. And past something like 4 weeks, you're really left with a model whose forecast is going to be really driven by the assumptions that it's making.
Yeah, absolutely.
If
we had in April, nobody could have predicted that we were going to see an uptick in Florida in July.
Exactly. Right.
I can't imagine any model being able to forecast that.
Right. So I think we and the CDC maybe in particular has been pretty reluctant to use these kinds of models to look that far out. So I think there's this common distinction that's made in the modeling community. I think it's been a little bit hard to communicate to the broader audience, but the idea that there are sort of two kinds of models, one that are these sort of strict forecast models that are really making unconditional predictions about the future, and they're sort of willing to have you hold their feet to the fire about what numbers they're actually saying. And then there are these other models that come out that are these sort of longer term projections, and I sometimes refer to them as like what if scenarios. These are what if models. What if we have interventions are relaxed a month after they start, or you sort of make some assumption that's built in that people are going to start complying less. What if that happens? Or what if we continue to comply perfectly with restrictions? But you get into this business of having to make so many assumptions, and we don't feel like we have good data to evaluate which assumptions are valid, which is why we've sort of limited ourselves to a very short time frame.
Okay, good. I'm going to ask you about that next, but before I do that, there's a question from the audience related to CDC. What do you expect to happen now that reporting to CDC has stopped and has been switched to HHS?
So that's a great question. Basically, our case and death forecasts are not dependent on this recent decision that that switched reporting of some data, and I think maybe in particular hospitalization data from CDC to HHS. So we rely, the sort of foundational data source that we've used from the very start is the Johns Hopkins CSSE dashboard that probably many of you are familiar with. It's the it's sort of one of the few sort of independent, third-party, non-governmental affiliated places that's really very carefully tracking and updating data. And so they use data that are pulled directly from state and local health departments. And those data are obviously unaffected by the political the political decisions. I do think we do also collect some hospitalization forecasts, and this decision does impact that, because we were encouraging teams to look at hospitalization data from NHSA, which is the group at CDC that was basically cut off from the new data. So I think that will be a challenge for hospitalizations.
Okay, interesting. So when what you request the submitters to report or to upload is just the forecast, or do they need to upload the model and the features? And if it's just a forecast, they can use whatever they want to predict, right?
Yeah, we just ask for the forecast, and yes, they can use whatever they want. So it's very very model agnostic.
So you don't know that. One of my questions was like, do you know what each model's doing?
Well, in theory, we know. I mean, everybody is supposed to provide at least a little bit of information, and you can see that. Well, maybe I can.
Yeah, I get it.
You can sort of. There's like a metadata file for each thing that talks a little bit about what they're doing.
And can you tell us a bit about just very briefly, what kinds of models are you getting? Are there? And I'm interested in hearing about how many are completely data driven, like just spline and move forward, and how many are trying to model mathematically what's actually happening. Do you have a sense for that?
I do have a sense for it, although I think the line is not as crisp as it sounds like it could be, because I think quite a large number of models claim to be and have underlying them a sort of epidemiological dynamical model, one of these models that where you have compartments and you have susceptibles, infected, recovers, this sort of exactly. So a lot of them have that sort of structure. So for example, the UCLA model, the UMass McBay's model, even the YYG model, a lot of these have an underlying compartmental structure that's driven by epidemiology, but in a lot of those cases, maybe being a little bit over parameterized for what I think this particular solution, this particular problem needs. And then there's a set of models that are sort of in name, they are these epidemiological compartmental models, but really when you get into the estimation, they're sort of flexible enough that epidemiological component, especially for the short-term forecast, isn't quite as meaningful. And then there are a small number of models, I would think maybe less than 5, that are really sort of purely data-driven, not pretending to be epi models, just kind of a time series ARIMA kind of model.
Yeah, and features, right, including a bunch of. I mean, I think if you include hospitalizations, that should do pretty well.
Yeah, but so here's the thing: is that the data quality is such an issue for all of these things, and hospitalizations, I think, I agree they should be a somewhat leading indicator of deaths, and probably are quite a bit more sort of better reported than, or in theory, should be a better indicator than cases, in the sense that case detection has probably been varying substantially over the whole course, as hospitalizations is a little bit more stable.
I see. But I guess I guess the best predictor must be the death the day before.
Yeah.
Right. And that once you condition on that, what's left is I guess like now I could see hospitalizations helping in somewhere like Florida, where there wasn't any deaths and now there are.
Right.
But in somewhere like New York, as it was going down, it was just like, oh, I just fit a spline, it's going down and you'll do well. I guess that's makes sense.
Yeah. So, I mean, here are three models that the model from Los Alamos, the model from YYG, which is, he's an independent data scientist, and then a model from my group at UMass in collaboration with some computer science folks. And these are three models that exclusively just use the death data. So they're all very simple. And it's interesting that they're actually seeing fairly different things here, but these have consistently been three of maybe the top 5 models in our sort of preliminary evaluations.
Sure, but I can imagine that the situation where there's no deaths or very few deaths, that there in those cases the hospitalizations and the cases will actually help predict, because you're starting with 0. Right? So you can only predict 0 going forward.
Right.
Right. So then to see that it's coming is that you see all these people going to the hospital, so you know something's coming. But yeah. I see what you're saying, that in most places where there's already a pattern to be estimated just from the data.
Yeah.
It's got to be the winner. So then that's interesting. So that was like a follow-up question to that I think you already answered, is like, how much do we need like knowledge of like context knowledge or subject matter knowledge here? It seems like not really that much, but maybe there is something that I'm missing.
I think the answer really is, for these particular outcomes in these particular locations, there is not a lot of sort of knowledge about different data sources that are or sort of knowledge about particular model, epidemiological model structures that are buying people big advantages. Mm-hmm. I think that I could see scenarios where those would start to be advantageous. We've seen in a couple counties for the UMass model, we've started modeling at the county level a little bit, and there have been a few places where our model has started to predict a sort of turnaround. So it's for the first time, it's basically just been, if you see some exponential growth, it's just going to keep seeing it. But in a few places, I think maybe Corpus Christi, Texas, has seen a lot of case growth. It's not super big, but it's near other urban areas. And we actually predicted in a sort of 8-week ahead forecast, we saw a turnaround. So in that case, maybe we're getting to maybe there's a new period of the outbreak as cases increase and we get closer to a time when we might be depleting the number of susceptibles in the population. I mean, that's the thing that the epidemiological models could help with. Early on in this stage, it really is just growth, right?
No, I can see it, yeah. Yeah, sure. Going forward, things like that. And also like behavior. Now that we know it's here, people, as soon as they see that it's going up, they might change their behavior a bit. So there are a few models that account for that, sort of bring in these like Google mobility metrics. I think the model from University of Texas, I think possibly. And how do they do?
They have been pretty good. Okay. But you can see here, I mean, the University of Texas model, well, I guess there are 2 models that are based on mobility. The Notre Dame one, which is pretty low. This is for Texas from a few weeks ago. And the University of Texas model saw a little bit of an increase there, though.
So I'm sorry, I don't actually understand all that you've been showing us right now. So in this plot, the gray, you're looking at forecasts that were done 4 weeks ago. Now, is that the idea? So the gray is.
this is like our current forecast. Well, as of a week ago, the forecast that were made from this select, I have been just sort of manually selecting a few models. And then, you can sort of go back either with an arrow key or with the arrow, with your mouse, and just kind of go and look and see what the forecasts were in the last few weeks.
Very nice.
So
I see. So nobody picked up the uptick.
No, not
at least these 5.
Not 4 weeks ago. Here's this one. Got a little bit.
Who's that?
Ago. I think that might be the UMass model.
So, one question from the audience: do any of these models use data from other countries? I can see that, like trying to figure out the shapes and.
That's a really good question. It's possible that the newer IHME model does this. I know there are a couple models that really that integrate a lot of data. They are running one of the bigger models. Them and maybe LANL and YYG have models running at the county level, at the state level in the US, and for many countries. So I don't know the extent to which those models are sort of hierarchical and borrowing information about the shape of curves from other places. I don't know the details of that. This is one of the challenges of doing this is, there's so many models, they're all so interesting.
Sure, yeah. And you have other things to do. Maybe when it's all said, when this is all done, you can go back and study this to learn for the next one. So now, the last question from the audience: do you think newer drugs impact the mortality rate based on models?
I would say my intuition about the answer to that question is not driven by the models that we have here, but maybe more just driven by observations of the match between cases and deaths 3 or 4 weeks later. So I do think that we're seeing, there's something has changed between when we were running things when the outbreak was starting, and we were seeing so many deaths in New York and New Jersey and Massachusetts, and now where we're seeing a lot of cases and proportionally fewer deaths. So I think certainly better treatment and sort of having better treatment could likely be a contributing factor.
I think my understanding is that the main reason is that we're being more careful with the retirement homes. That's like one big factor that is
absolutely
different now than it was.
So I think I would not put the better treatment at the top of the list of things that are impacting it, but I think better treatment, better quarantining of people who are at risk, and those people really taking it quite seriously. Mm-hmm. This sort of slightly different, I think just we are doing better. We are doing more testing. I think that is changing the number of mild cases that we're detecting. Mm-hmm. And I think younger people are more getting sick more often. That's sort of shown in the surveillance data pretty well. So it's a slight change, but there are a handful of these things. But I agree that protecting vulnerable populations is I think making a big difference.
So I would love to see, you don't have to show it to here, but if it's there, I'll look at it later. Is there like a standings, like who's do you have that? And a related question, do you can you tell us a little bit about generally how well these things are doing? Like what's their coverage? Like how often is a 95% confidence interval actually include the prediction? Yep. And what's the variability from the worst to the best? Is there a clear winner?
So we have some. So this is actually the fellow who makes the YYG model. He has a nice website. He projects far out. He's not an infectious disease modeler, but he's been very open and transparent. His software is available online. He's had these sort of honest historical performance evaluations. So we are working on building a scoreboard, but it's a little, we've been slow about it because we've wanted to be careful about the perception of critiquing teams and stuff like this. So I encourage, this is publicly available. He updates it every week. And this is, I think, where this is where I go to get my sense of what
and I can't see everything here, but
models are doing well.
does this include full coverage? Because
no,
like
so this is one critique. He's just evaluating point by point. So I can show you maybe one figure that we've done. I mean, we have not looked in detail at across models, but we have looked at the ensemble, which I saw there's a question about the ensemble, and I can answer that briefly. So this, can you see here? Okay. So this is.
Yeah, we see it. That's for the ensemble.
This is for the ensemble. So
look at that. That's amazing.
So it's pretty good.
Yeah.
We found in the process of doing this and trying to actually sort of write up something about this, we found a small bug in that, because of the way we're building the ensemble, when a place has 0 deaths, the moment that any prediction is not, its 95% prediction interval doesn't cover 0, then you're sort of pulled away from 0 just a tiny bit, and so then you don't cover the truth. And so this is something that we're in the process of changing, but you can see that we do quite well when we exclude weeks that have 0 incident deaths. That's the sort of lower set here. And then at least for the 95%, where it's a little bit lower when we just look at all weeks. So this is something that we were glad to have looked at in more detail, because we were like, oh, this is.
So the aggregate is it much better than everything else, or is it competitive with the best ones?
I would say it is competitive with the best ones. We so at the current moment, what we're doing is we're taking a simple equally weighted average.
That's one of the questions from the audience.
Yeah, exactly. So we're taking all these models, we're passing them through some fairly basic quality control tests, to just make sure that they're not doing something completely wacky, including a visual spot check, and then we're taking the remaining models that pass it through those quality control checks, and we're taking a equally weighted average of those. And
I gotta interrupt you and say that you're doing a visual spot check. That is very important and so often not done. I can't even believe how that's actually a rare thing to do, but I bet you find so many errors that way.
We do. I can show you a few, actually, because we do. Let's see here. So we have, we've seen just like predictions like this.
Yeah.
And occasionally things like this, which are sort of hard. This is cumulative death, so this really should be just sort of a continuation here, and this is clearly just sort of shifted somehow wrongly. And then occasionally things that are sort of horrendously pessimistic in a way that we think is really unrealistic. So, so we do, we try to have a light touch, because we really don't want to let our own biases come in, but it's sort of inevitable that we have to do some corrections. And we've formally evaluated that procedure, and we've like what happens when we don't do those corrections, and it's very clear that it's making a difference. We are moving towards a setup where we would estimate weights based on past performance. This sounds like it should be sort of a no-brainer. I mean, it's sort of one of the things that people who think about prediction, it's like their first question often. And it turns out it's been harder than we would have thought to beat. Well, harder than a lot of people thought. I think we knew it was going to be hard to beat an equal weighted ensemble, which is why we started there. But it's been hard to beat that. And I think part of it is because the models are changing quite a bit over time. IHME had this really simple model early on, and then changed to a model that is really quite complex and doing quite a bit more reasonably in recent weeks. But really all the models have changed, the sort of fundamental structure change, because they're all being actively developed.
Interesting. And just do you have one that's just like extrapolation, spline extrapolation, just as a straw man?
Yeah, so we have this thing that we're
And where
calling
does that rank in the?
so that's this. It's essentially just takes whatever the number of new deaths to happen last week, and it just extrapolates that forward using resampled differences from previous observations. The best place to see where that is doing well. So there's a version of that basically on that YYG scoreboard that I showed before that's online. He has a sort of point, not a probabilistic version of that. And again, it does better than all but maybe 4 or 5 of the models. And
tell Ryan Tibshirani that I thought about it before he did. I just
okay. So yeah, I mean, what we've seen is that really only 4 or 5 models consistently can beat this. Mm-hmm. I will say that that's based on the last maybe 2 months or so of performance, and the last 2 months have been pretty flat in a lot of places. So I think that's maybe not a terribly fair indicator of how it will do in the future.
All right, great. Well, we're running out of time. I don't want to take too much more of your time, but I do have 2 more questions. The first one is, would you add Puerto Rico to it if I show you where the data is?
Yeah, so we actually, Puerto Rico is here, but sadly it's not in our map. in our map.
Just make it really big and put a big star on top of it. No, yeah, okay. So,
but it is in the, if you go to the CDC, I'm clicking around and I'm not sure.
Okay, I got you.
But yeah, if you go to the CDC thing and look at their state forecasts, it's included as a state and territory.
Can I pull? So I'm keeping a dashboard for Puerto Rico. Can I pull that graph easily? Maybe you can tell me later, so I can just add it to the dashboard.
Yeah.
Just a prediction one.
Yeah, so probably you could do one of a couple things. You could either use the API to this database backend that we have, or you could pull off the CSV files from the GitHub repo, and there's a folder for the ensemble just like any other model. And I mean, again, all this data is public, so it's not just for you, Rafa, but for anybody here if you want to fiddle with the data.
And we would do it for cases because there's too few deaths right now to do anything useful, I think. All right. So the last question is, what have you learned? What do you know now that you didn't know in March? And that's the question. What can you tell us about what you've learned through this process?
So I'll say that when we started in March, I felt like we had a pretty good, we were feeling pretty good about our understanding of how prediction models could work for an endemic seasonal disease like flu, where we have 20 years of data we can train on, and you have models that can all do fairly reasonable things right out of the box. And so one of the things that has been most revealing about this is sort of how a set of sort of new models that are developing as we go can work for a data set that is sort of emerging before our eyes, where there's sort of no precedent for it. Mm-hmm. I've been, I think, a little bit surprised at, so I guess I'm going to answer you give you a sort of model oriented answer to this question. I think I've been surprised at how hard it has been to beat this equally weighted average. I had sort of expected that sooner in the game there would be a sort of more obvious benefit for weighting the models. And it still feels like sort of like black magic to me that you can just sort of take an average of models that are doing reasonable things, and that continues to be a sort of really hard thing to beat. It's like these biases are averaging each other out in some way that that's just hard to replicate.
Good. All right.
Great. If I may say just one more thing to all the folks here who are here listening, I really appreciate that so many folks have tuned in and are showing interest in this. So I just want to say this is I'm here as sort of the spokesperson for this much larger group of people who have been really, who are making this run. And so I'm really grateful to all of them. And of course, grateful to all the teams who have participated and are sort of, putting their data out publicly under very generous open source licenses for use. We would love to have folks, more eyes on this data, more people pawing through it and making use of it. There's room, so we'd be happy to, all these resources are open and free. We encourage people just to go and make dashboards and whatever. And if there's anybody who is interested in sort of getting more deeply involved with the hub itself, there are plenty of opportunities. There's so many things that are falling by the wayside in our effort just to sort of keep this going operationally week to week. So, if there are folks who can fold this into their day job as a student or professional, we'd be happy to talk. We're probably going to be hiring a full-time software engineer to work on this starting in a month or so.
Good for you. Great.
Yeah.
All right. Well, thanks again.
Thanks, Rafa.
We really enjoyed it. It's been very educational. We'll be putting this on YouTube so you want to share it later, and we'll announce it on Twitter. And if you don't have a Twitter account, we'll email you so you're aware. Okay.
Great. Thanks again for having me, Rafa.
Thanks again. Bye-bye.